Well, good afternoon from Greece. I'm Professor Skolarikos, Professor of Urology from Athens Medical School. I welcome you, all of you, to this webinar regarding the metabolic evaluation of our stone patients. Just to remind you that at the end of my presentation, you will be able to ask questions. So you have been taught to do it through the system. So please feel free at the end to ask questions. I have no conflict of interest. Of course, I'm a part of the EAU guidelines for stone disease, and a lot of what I will present you today, this afternoon, it is included inside the big book of the EAU guidelines on urolithiasis. So you will be able to find it there. The topics that I will cover regarding the metabolic evaluation is a little bit about the stone disease profile, to see the rationale for the metabolic evaluation of our stone patients. We have to answer two questions. Do we need a metabolic workup, and whether there is a specific metabolic evaluation really prevents the stone recurrences? If it is cost effective, the metabolic evaluation, and then the presentation will be more practical. What are the aims of the metabolic evaluation? To whom, when, and how we should do it? And how to follow up the high-risk patients, and at the end, I will show you as some examples, some metabolic cases, and how you can do it in your everyday practice. So the disease profile, you all know that the incidence and the prevalence of stone disease is related to young population. So the first episode is around 25 to 49 years. We are talking about young people. And 20% of the patients will experience more than 3 stone episodes during lifetime. Regarding the stone recurrence, it really depends on how long you will follow up your patients. So if it is for 5 or 10 years, approximately 50% will recur. But if you follow the patients for more years, let's say up to 25 years, then all of our patients will form a stone again. And the risk of recurrence increases 2 to 5% per year for each new stone, new stone that the patient forms. And this is irrelative to the stone type. We all know that non-calcium stones, like the infection stones, brucite, uric acid stones, or cystine stones, are prone to recur highly. But also the calcium oxalate stones, half of our patients can have a stone back. So the first question is whether we need the specific for our stone patients. Why? I think we have to follow what Aristotle said. All men by nature really desire to know what this means. If a patient comes to you with a stone and you operate on the patient with a PNL or ureteroscopy and the stone is out, then the next question the patient will tell you is, why did I form the stone? So why metabolic evaluation? If you had a stone yourself or one of your relatives, then you know that you don't want another. And of course, we all know that the removal of the existing stone does not really prevent from further stone formation. But there is also other reasons. If you have kidney stones, you can end up with end-stage renal disease or chronic kidney disease. And actually, the risk factor either for the first kidney stone episode or the second kidney stone episode is approximately doubled for end-stage renal stone disease. So stones can affect the renal function. There is a great diversity of etiology also. This is another reason why we should follow up our patients and evaluate our patients, because if you have a calcium oxalate stone, it doesn't mean that all the patients have the same etiology of the stone formation. And what we know that if you follow up the patients for a long time, then you may reduce, and that was shown very early by the bone team in Germany, you can reduce the recurrence rate by 46%. What they did, that was achieved by an extensive metabolic evaluation in every stone person. If it is needed to do an extensive metabolic evaluation to all of our patients, we will explain in the next slides. What is the evidence, though, about the dietary and pharmacologic therapy in preventing stone recurrence? We have systematic review and meta-analysis. The more recent one is a few years ago, that they included 28 randomized controlled 8 about the diet and 20 about the pills that we are giving to our patients. Most of the studies were about the calcium stone patients. And they have looked about the systematic stone recurrence or the radiographic recurrence or the composite recurrence, meaning if they formed another stone. And the treatment duration was approximately 1 to 5 years. That is a very short duration, as I said, to follow up our patients about the stone recurrence. And the vast majority of the trials were of fair quality. So unfortunately, we don't have high quality studies on randomized controlled trials on the topic. What we have seen, just remember, if you give thiazides, citrate, and allopurinol, then you will reduce stone recurrence. So we have systematic review and meta-analysis that the pills really help our patients. Is it cost effective, the metabolic evaluation? It is well known that the reimbursement for stone surgery is by far higher to the reimbursement of the metabolic evaluation. This is why most of us, we love to do surgery, of course, as surgeons, but also because of the reimbursement. But the cost, as you can see, it is expected, is very high, the cost for surgery, and it is expected up to 2050 to be increased by 25%. So we are talking about a lot of money, not only at the States, but also in Europe. If you compare this cost to the screening and the drug treatment, you can see is very, very cheap. So I think we can save a lot of money for our patients if we follow up them and if we evaluate our patients and if we give drugs to prevent the stone recurrence. And how much money we can save? It is from in Germany, from the Coburg Clinic. You see the amount of money they saved, at least they judged they saved, was tremendous. And this is approximately the same to the rest of the Europe. Now, let's become more practical. What are the aims of the metabolic evaluations? What we should look when a patient comes and he has been operated for a stone, let's say, or he had a lithotripsy for a stone, and we want to see why he formed the stone. So what we have to see is to obtain the insights of what the patient really eats. It's very important. We have to diagnose systematic causes of urolithiasis. We have to estimate whether a particular patient has a great or a higher tendency to crystallization. And we have to determine whether the patient is at risk for chronic kidney disease or metabolic bone disease, because there is a correlation between stones and metabolic bone disease. So obtaining the insights on dietary habits is very important. You all know that eating a lot of protein and a lot of salt really predisposes to stone formation. So you need to ask the patients about their eating habits. How do we do that? We can do it with either weighted or estimated food records, the dietary recall, the food frequency questionnaires, food screeners, or nutritional biomarkers by measuring them. Most often, it is the dietary recall that we discuss with our patients when we see them either in our private office or the outpatient clinic. The second thing that we have to discuss with the patients and to evaluate is whether there is an underlying systematic cause that the patients really have to form stones. And you will find these risk factors within the guidelines text. So if we have general factors that predispose to stone recurrence. So if you have children or teenagers with the stones, they are at high risk for stone recurrence. If your parents have had stones in the past, then you are in a high risk group for stone recurrence. And of course, we all know that if you have a brucite or uric acid or infection stones, then you belong to a higher risk group. Several diseases associated with stone formation. If you have an untreated or uncorrected hyperparathyroidism, then you are tended to have more stones in the future. And of course, nephrocalcinosis, sarcoidosis, or if you had bariatric surgery or several GI diseases like the bypasses, the intentional bypasses, though they are prone to form more stones and for their stones to recur. There are several genetic causes of stone formation, like cystinuria or primary hyperoxaluria, or the RTA, the renal tubular acidosis, that we will discuss in detail. So if you have a patient with cystinuria, then you know that unfortunately, if he doesn't follow the treatment, he will or she will recur. Anatomical abnormalities associated with stone formation, the UPJ obstruction, the medullary sponge kidney, the calyceal diverticulum, and you have to think that this is not only the anatomy and the stasis of the urine that are really predisposed to stone formation, but these patients may have also metabolic factors predisposing to stone recurrence. Then medications. You have to discuss about the pills the patients are taking. And of course, there is an endless list. It's not for this webinar to go through all, but you will have it as a list, and you have to discuss about the medications. They are very rare. How often we see drug stones? Not that often, honestly. The third thing that we need to discuss with our patients is to estimate about the urinary tendency the patients have to, a specific patient has to crystallization. How do that? There are several indices again that you can use, and you see it on the table. Is this for common practice? I wouldn't say that this is used in common practice, but you can have it if you want, you can have it, or you can use them for scientific purposes. If you ask me how often I use these indices for my clinical practice, not that often. Last but not least is to determine the risk that the specific patient has for chronic kidney disease or metabolic bone disease. So if you have patients with distal tubular acidosis, medullary sponge kidney, hyperparathyroidism, or malabsorption syndromes, then they could be prone to metabolic bone disease. So keep that in mind and discuss with a specialist, either a nephrologist or an endocrinologist, because you are not experts about the metabolic bone disease. But we have to think and evaluate the patients for these. And of course, risk factors for chronic kidney disease, you have to be very careful when your patient has brucite stones or xanthine stones or cystine stones or infection stones, because they may end up with chronic kidney disease. So we need to evaluate and follow these patients up. Becoming even more practical, to whom and how? And I think that this algorithm is the most important algorithm that we have in the guidelines. So if a patient comes to you with a stone and you have operated, or if it is a stone patient, there are two options after that. Either you know the type of the stone or you don't know the type of the stone. Two different categories about the patients. The stone analysis is unknown in approximately 30% of our patients. Most of the time we operate, we take a sample and we have the stone analysis. So what will be the next step? The next step, if you don't have the stone analysis, is how to investigate these patients. And then you have to take a thorough medical history about the stone history, the dietary habits, the medication chart as we discussed. You have to do imaging. You have to do a blood analysis with creatinine, calcium, and uric acid, and perform a urinalysis for a pH, urine culture, a dipstick, and a microscopy, mostly if of a morning urine, mostly culture when you want to intervene with the patient. So go back to this algorithm. If you have operated on a patient and you know the type of the stone because you sent it, then you have to send it, as I said, for analysis. And how do we do it? Perform the stone analysis. In all first-time stone formers, this should be a must. As I said, we are able to have it in approximately 70% of our patients. And by using a valid procedure, and X-ray diffraction or infrared spectroscopy is the most common diagnostics that we do. But you have also to repeat the stone analysis in patients presenting with recurrent stones despite drug therapy, or to those patients with an early recurrence after complete stone clearance, or with a late recurrence after a long stone-free period because stone composition may really change. And you see the recommendation that we give within the guidelines is extremely strong. Although the level of evidence of the literature that we are having is not that high, the recommendation is strong. Going back to the algorithm again, when the stone analysis is known, then you have to do a basic evaluation to every patient. So what is the basic evaluation? Again, under strong recommendation, a dipstick test or spot urine sample for red cells, white cells, nitrite. Urine pH is very important. Urine microscopy is very important. Culture is if you really, there is a possibility to intervene, operate on the patient. Blood examples, blood samples also for creatinine, uric acid, the ionized calcium, sodium, potassium, the blood cell count, C-reactive protein, if an infection is there, or if you think that you have to operate on the patient. So if you have the stone analysis known and you did the basic evaluation, or you investigate the patient when you don't know the stone, then the next step is to give general preventive measures to all patients. Everybody should do that. So fluid intake, you have to drink a lot. That's exactly what we are advising our patients. How many? 2.5 to 3 liters a day. It is more important to know that they will void approximately 2.5 liters a day, but it's difficult to document. So we advise to drink a lot. Nutritional advice of a balanced diet. Balanced diet means rich in vegetables and fiber, normal calcium content, because if you don't eat calcium with your diet, then you leave oxalate in your gut to be absorbed and to pass into the urine, and then you form oxalate, calcium oxalate stones. Limited sodium content, 4 to 5 grams a day, and limited animal protein content. So it's approximately up to 1 gram per kilogram per day. Lifestyle advice, Of course, you know that you have to, your BMI should be within the normal range, because the metabolic syndrome is really one of the most important causes for stone formation and stone recurrence. What is the level of evidence and the grade of recommendation for these general recommendations? Is the level of evidence is high and the recommendation is strong. And the highest level of evidence that we have randomized controlled trials and we have meta-analysis, is about the increased fluid intake. And of course, the recommendation as a consequence is strong. Go back to the stone. A patient comes with a stone, you either know the stone type or you don't. You did a basic metabolic evaluation, you investigated the patient, you have given advice, and then you have to think, are there any risk factors about the patient, risk factors for them to have the stone back? If there is a low risk, then general preventive measures is all they need. But if they have, and what we are saying about the high-risk stone formers, once again, through the guidelines, the general factors as we discussed, the genetic diseases, the diseases associated with stone formation, the medication that the patient is taking, and of course, if there are several anatomic abnormalities, then the next step is to do a specific metabolic evaluation. Approximately 25% of our patients are prone to have high risk for stone recurrence. And when we are talking about the specific metabolic evaluation, means 24-hour urine collection. So I will give you within the next 2 or 3 slides some tips and tricks about the 24-hour urine collection, because although we ask for it, I'm not sure that a lot of us know exactly how we do it. So we need 2 consecutive 24-hour urine samples, because it has been shown that they are more accurate in evaluating our patients. The collecting bottles should be prepared with 5% thymol in isopropanol or stored in less than 8 Celsius degrees to prevent spontaneous crystallization. So we need real results. Alternatively, you can use boric acid, and I will show you in the next slide about this. The collection, and this is very important, should include all the urine that a patient passes in a 24-hour urine 24-hour period. Why? If you miss one, if you forget to collect just one pass of a urine, then you have to redo it from the beginning. So you have to advise your patient to take a 3-liter capacity containers, and you have to ask the laboratory what exactly they want to add as a preservative. It's not for us to do it, but everybody knows that they use it. If a preservative is used for a specific analysis, then you may have to collect it on a separate 24-hour urine sample. And you need to discuss if you have to add acetic acid for measuring the magnesium, then you may not be able to correctly measure oxalate. So you need to discuss very thoroughly with the lab test. And of course, this is just for the webinar, the urinary preservatives, how you add them. It's not for the webinar to discuss. So the container should be colored if you have preservatives. Otherwise, the light may destroy them. The preservative is added to the collection container before the urine collection begins. We have to keep it in storage refrigerated or in the bathroom on ice, and this is very real. Otherwise, we won't get, we will have crystallization spontaneous, and we won't know the real results. On the morning of the collection, the patient he has to empty his or her bladder and not collect this urine sample. Then you have to collect even the urine passed with bowel movements. Not a lot of urologists actually know that. And you have to collect the first urine passed the next morning, 10 minutes before or after the time of the first morning void of the first day, which was flushed. That is the 24-hour urine collection. That is the appropriate how you should do it in the right way. And of course, if you need to urinate 1 hour before the final collection time, you have to drink a full glass of water so that you can void again at the appropriate time. And if you have to urinate 20 minutes before, you may have to, you may say to the patient that you try to hold the urine until the proper time. They have to bring the urine to the lab as soon as possible to transport it in an upright position. And of course, if the weather is very warm, it's very important to advise them to put the container, the urine container, on ice in a cooler. All these are tips and tricks for the 24-hour urine collection, but they are very important for the right measurements. So one of the most difficult things about the evaluation of our patients is about the medications. They are difficult to deal for urologists to deal with medications. But there are not that many of the pills that you have to remember. There are approximately 9 drugs that you have, and you can remember that for calcium oxalate stones, you can give almost all of them except for the chelating for cystine drugs and the antibiotics. And then if you have to remember this table, you see that for Strovit stones, there are a couple of drugs that you need, like the L-methionine for acidification, and of course the antibiotics. And for cystine is the alkalinization and the chelating agents. So there are not a lot of medications that you have to remember and deal with for your stone patients. But they can also cause adverse effects, and you have to know them. And I won't go through all of them, of course, for this webinar, but it's very important to have a small table and remember what are the adverse effects of the medications that you provide to the patients. So I will start stone by stone to give you the examples and the diagnostic and the therapeutic algorithms that we have created within the guidelines. So if you operate on a patient, you do a perk, and he or she comes with a cystine stone. And after that, you do the basic evaluation, as we discussed, and then you have to treat the patient. So the appropriate hydration with more than 3.5 liters a day in adults is very important. And this is the formula for children, for those of you that you are dealing with stones in children. And of course, you have to alkalinize the urine, and you have to reach a pH between 7.5 and 8.5. And how you do that? With alkaline citrate or sodium bicarbonate. And it really depends further treatment on the cystine excretion within the 24 urine sample that you collected. If it is less than 3 millimolar per day, then you may give chelating agents like tiopronin. If it is more than 3 millimolar per day, then you have to give tiopronin starting from 250 milligrams per day up to 2000 milligrams per day maximum dose. What is the level of evidence about cystine stones? We don't have randomized controlled trials. It's not possible to do randomized controlled trials on these patients. I'm not sure if it is also ethical. The level of evidence is low, but the recommendation about the treatment that we give is strong. We don't have anything else. And just remember that the dilution of cystine and the prophylaxis depends on the urine pH, and you need a higher pH, more than 7.5, to achieve. Then a patient, you did a perk on an infection stone. You have to identify the predisposing stones for Strovit stone formation, and you can see that if you have urease producing bacteria, then these patients are predisposed to reform infection stone or struvite stones. And this is very well known to the urological community. Just remember that there are some strains, very few of them, of E. coli or Enterococcus or Pseudomonas that may produce urease. So do not say that E. coli does not. It's not that common, but it can happen. So if you have an infection stone, it can be either struvite or carbon apatite or ammonium urate. And ammonium urate we will discuss with uric acid stones. So if you operate it on a patient and the patient has an infection stone, then you do the basic evaluation. And if you find urease producing bacteria, or if it is the urine pH is high and then you suspect a carbon apatite or a struvite stone, the treatment should be the complete surgical removal. It's very important. Is it possible? Not always, but it's very important. And then if you leave some fragments behind, then you can chemolyze them. Maybe a useful adjunct. How often we do it? Not that often anymore. You should give antibiotics, short or long course, we say within the guidelines, but we are not sure what exactly is short and what exactly is long. We are sure that we have to achieve negative urine cultures. For how long we give it, we don't have high level of evidence. Urine acidification with ammonium chloride or L-methionine, 200 to 500 milligrams 1-3 times a day, or 1 gram twice or 3 times a day, it is not that often that we use in our clinical practice. More often, we give the L-methionine. It's difficult to reach in several European countries. Urease inhibition with AHA, then this is the highest level of evidence. We have a randomized control trial, but the recommendation we give due to the side effects is very, very low, as you will see. So as I said, the level of evidence is not that high, unfortunately, for the infection stones. The strong recommendation that we give is to completely remove, if possible, the stone and to prescribe antibiotics. The recommendation is very weak for ammonium chloride or methionine, mainly due to the side effects and to the patients, to the low compliance of the patients. So remember, the medications, to summarize, for struvite stones is complete stone clearance, antibiotics, and L-methionine achieving a pH of 5.8 to 6.2. Urease inhibition is very, very controversial. Now, if you have a uric acid stone, you did a ureteroscopy, you remove the stone is a pure uric acid. You have to think what is the etiology behind. It could be because of low urine volume, like in chronic diarrhea. It could be because of hyperuricosuriia. When can you have this? If you have some enzymatic deficiencies, or if you overproduce urate, if you have gut, or if you eat a lot of purine, let's say, then there are different causes. So you have to advise. That is the evaluation. If your urine is acidified, so if you have low urinary pH, that can be, again, to different causes like diarrhea or high animal protein intake. So you have to go through the diagnostic algorithm and give, try to correct, and of course advise your patient accordingly. So for the ammonium urate stones, the etiology could be either urinary tract infection, hyperuricosuriia, malabsorption, or malnutrition. Then if you have the uric acid stone, this is the therapeutic algorithm. So first you have the stone, you evaluate the patient, then you have to think why they formed the stone. Not all uric acid or urate containing stone patients have the same reason they got the stone, and then you have to treat them. If your patient has an ammonium urate stone, after the basic evaluation, You measure the urine pH is more than 6.5. If there is a urinary tract infection, you give antibiotics. Or you may have to acidify the urine with L-methionine. And of course, as I said, correct the factors predisposing to ammonium urate formation. If the patient has a uric acid stone following the basic evaluation, if the patient is hyperuricosuric, depending on the level of the uric acid they have in their 24-hour urine collection, or depending on the level of the uric acid they have at their blood, you can give allopurinol on a low dose or on a higher dose. If there is a uric acid arrest with a urinary pH of less than 6, then you alkalinize the urine with alkaline citrate, 9 to 12 grams per day. And the dose actually really depends on whether we need to prevent a new stone formation or to dilute and release one of the stones that really exist. So for prevention, the urine pH is between, the achievement should be between, the goal should be between 6.2 to 6.8, and a little bit higher when we need to dissolve the stone. So what is good on these algorithms, and I will explain with the calcium oxalate stones, you may not remember all these in your everyday practice. So what I do is I consult the patient comes after the operation, so I have the stone analysis, and I'm using these tables in front of me, these algorithms, to go through their treatment. The level of evidence and the recommendation about the uric acid stone is quite good for the allopurinol. For alkalinization, although we use it, is not that high. The recommendation is strong for both alkalinization and allopurinol in uric acid stones. And regarding the oral chemolysis for uric acid stones, I think it's a strong recommendation to advise the patients to monitor by dipstick and to modify the dosage depending on the urine pH. Then to carefully monitor the patient, this is a must after oral chemolysis for uric acid stones. So for uric acid, to summarize, you need to remember the alkaline citrate, different doses about chemolysis and prevention, and the allopurinol. These are the two drugs that you have to remember. And of course, diet, rare impurities. For ammonium urate is allopurinol, and you have to treat the infection therapy. L-methionine really is very rare that we are using. Calcium phosphate stones, again, the therapeutic algorithm. Calcium phosphate are two different stones. Brucid stones, after the basic evaluation, two causes, hyperparathyroidism or renal tubular acidosis. And if there is hypercalciuria, more than 8 millimolars per day, then you give hydrochlorothiazide on starting from a low dose and up to 50 milligrams per day. If you have a carbon apatite stone, after the basic stone evaluation, after the basic evaluation of the patient, if you have hypercalciuria, you give hydrochlorothiazide. If your urine pH is more than 6.5 to 6.8, you have to exclude either the urinary tract infection or the renal tubular acidosis. And of course, you have to adjust the urinary pH, and then you may have to give L-methionine on these patients with carbon apatite stones. How should I remember this? I don't remember this. If a patient comes and the stone analysis is a calcium phosphate stone, then I have to go through the algorithm in front of my desk. The level of evidence is about the thiazide in hypercalciuria is high, the rest level of evidence is low, and the thiazide prescription is strongly recommended within the guidelines. We are talking a lot about the renal tubular acidosis. If your urinary pH is constantly more than 5.8, then you can perform the ammonium chloride loading test. You have to discuss it with the lab how you do it. If the urinary pH after the loading test is less than 5.4, then you don't have a If it is more, you may have the blood gases, the bicarbonate in blood gases, it will be incomplete or complete if you have low bicarbonate in the blood gas. How often you may have alkaline citrates on the doses that are between 9 and 10 grams per day. The level of evidence is not that bad, and the recommendation for thiazide again and potassium citrate for hypercalciuria is strong. For renal tubular acidosis is weak. So about the calcium phosphate stones, you have to remember only 3 medications: the thiazides, the alkaline citrate, and L-methionine. And you have to exclude hyperparathyroidism, renal tubular acidosis, or a urinary infection. Remember that the Brusik stones are different to carbon apatite stones. Last but not least, because this is the vast majority of the stones that we are having calcium oxalate stones every day in our practice. So not every patient with a calcium oxalate stone has the same etiology for the stone formation. So you may have your patient hypercalciuric, and this can be along with normal calcium in the blood, hypercalcemia, or normal calcemia and metabolic acidosis. This is the diagnostic algorithm. So if you have a hypercalciuria and normal calcium in the blood, then you may have an idiopathic, we don't know the cause of hypercalciuria. This is the commonest type. If you have hypercalcemia, think about hyperparathyroidism. And if you have metabolic acidosis, then RTA could be the cause. If your patient has a calcium oxalate stone and he is hyperuricosuric, then he may eat a lot of protein, or he may have a problem with his blood, let's say, or a myeloproliferative disorder. If you have hyperoxaluria, 3 different types: the diartery in adults, enderic, like a small bowels resection, and of course the congenital, the primary hyperoxaluria. Now, if you have a patient operated with a PERC and the stone comes a calcium oxalate stone, you have to do the basic evaluation. And if the patient is at high risk, have the same risk factors that we discussed before for stone recurrence, then you have to perform 2 24-hour urine collections. And there are 5 results that you will get and that you have to treat. It will be the hypercalciuria, hypocitraturia, hyperoxaluria, hyperuricosuria, or hypomagnesiuria. And the treatment, if you have a calcium stone or a calcium oxalate stone and the patient is hypercalciuric, then you have to give alkaline citrate, depending on the levels of the calcium in the urine. If it is more than 8 millimeters a day, then you have to give also hydrochlorothiazide, starting from low dose and increasing the dose gradually. If the patient has low citrate in the urine, then you have to give alkaline citrate. If your patient is hyperoxaluric, and if it is a derrick, you chelate with calcium and more than 1,000 milligrams per day. And of course, you give some magnesium. If it is primary hyperoxaluria that most of the pediatricians are seeing, you can give pyridoxine. And if the patient has elevated calcium oxalate stone and elevated uric acid stone, then depending on the level of the uric acid, you give alkaline citrate plus low dose of allopurinol. If there is hyperuricemia also, you give higher doses of allopurinol together with alkaline citrate. If the patient is hypomagnesiuric, then you give magnesium supplements. What is the level of evidence that we are having? As I said at the beginning of my talk, we are having randomized controlled trials and a high level of evidence. So most of the recommendations that we give are strong recommendations. So what is, in summary, the medication that we need to remember regarding the calcium oxalate stones? alkaline citrate, thiazides, allopurinol, calcium, and magnesium. Not a lot, as I would say. Last but not least, how often and when should we follow up our high-risk stone patients, high risks for stone recurrence, and when and how often we will do the metabolic evaluation? The follow-up, I think, is very important because the goal is to see if the patients really take the pill that we advise them to take. Then to see if the pill that we are giving is effective or not. If we have to do adjustments on the medication, and of course to follow up the side effects and correct or treat the side effects. Now, the main question is how often and for how long? And actually, we don't have really a clue. What we advise is the patient should be on a self-determined diet. You have to do it when the patient is stone-free for at least 20 days. A single study, we are not sure if this is a must or not. You have to do it if you give the medication to your patient. The first follow-up, 24-hour urine measurement should be repeated 8 to 12 weeks after starting the prevention. And of course, you may have to redo it every 12 months, but we are not sure. The level of evidence is low. So most of the people, they do it at 3 months. Some of the people, they do it at 6 months. Most of the people, they are doing annually the metabolic re-evaluation. And for how long is the question? Well, I think it is lifelong, if possible, for our patients. Last but not least, I will give you a couple of clinical cases. Let's say that the patient is coming, a male, 46 years old, and this is the 24-hour urine that you can get. That is the numbers, and if it was a live interaction, I would ask what will be, if you see the total volume, I won't read it, what is the right answer on the right side. So you have the 24-hour urine, the blood test is normal, the stone is very late, 95%. So I think the right answer is C. The 24-hour urine was not well collected because you have to produce 20 milligrams per kilogram. It's very, very important. The total volume is very low. So you have to be very careful reading the results of the 24-hour urine collection. A second example, as a test, you will be able to see what are the serum and the urinary results of the 24-hour urine collection. What is wrong, what is right? The red is wrong. So there is an elevated calcium in the patient's urine, more than 300 milligrams per 24 hour. So what should I do? The stone analysis is 100% calcium oxalate. So I will give to this patient hydrochlorothiazide. How come? How this came to my mind? Because this is not our everyday common practice. Then I have to go back to the therapeutic algorithm that we created, and I have a patient with a hypercalciuria, and then we have, it is quite elevated, and then I will give hydrochlorothiazide and I will follow up the patient. The third case is a male. Again, we are having the 24-hour urine collection. The stone analysis is the 2 stones, one 100% calcium oxalate, and the second stone is a uric acid stone. So it's a mixed stone or 2 stones on the same patients. What is wrong? Again, if it was a live interaction, I will ask, but now I will give you the results. There is an elevated uric acid in serum, elevated uric acid in urine, and elevated oxalate in urine. So, and the case will give allopurinol on a high dose, citrate alkaline, and I will advise the general recommendation that we give for the diet: low protein, low salt, and a lot of water, up to 3 liters a day. How these medication came on this example, again, I'm going back to the therapeutic algorithm, and what this patient has had, has had hyperoxaluria, and that was enteric. So I will give some calcium also on this patient, because otherwise I wouldn't be able to chelate the oxalate in the gut. And then the patient has had also hyperuricosuria. And if you saw, it was hyperuricosuria and hyperuricemia. So I know that I have to give allopurinol on a high dose, and of course alkaline citrate. Another example, the stone is 80%, a mixed stone, 80% calcium oxalate dehydrate and 20% calcium phosphate stone. What is wrong with this lady? Almost everything is wrong, but as you can see, the PTH in serum is very elevated. And you can see that this is primary hyperparathyroidism, and is, of course, surgery or even medication with some new drugs could be possible. So this patient has to be referred to an endocrinologist. And again, I can advise the calcium phosphate stone therapeutic algorithm if I don't remember what exactly I have to do for my patients. Last but not least, this is another case. We have a urinary pH of 5.2. The left kidney stone is a big stone, and the stone volume is also big, but this is radiolucent. So we think that this is the 24-hour urine, and you see that there is an elevated uric acid in serum and in urine also, and this patient has had a 100% uric acid stone. What shall we do? Shall we do RIRS or PNL? I think the right answer is we can really dilute, and because the patient has had a big stone, we may need to leave a stent, but we can dilute. It may take for 1 centimeter stone a month. So for this lady, the medication lasted for 3 months until she became stone free. Again, I have the uric acid stone containing and urate containing stones therapeutic algorithm that I can see and take the advice of it. So the take-home messages, and after that we will be able to discuss and answer 2 questions. First of all, you need to take, when you have to evaluate your patients, a thorough medical history. You have to think about diet habits and systematic diseases. I think it's very important to follow the EAU guidelines risk table. If the patient is very young, if he has anatomic problems or a genetic problem, then they are prone to have stone recurrence. You have to have, in almost every of our patients, to analyze the stone, and I think this is very important because it really guides the treatment, as I said. You have to know that the non-calcium stones are of high risk for stone recurrence. The crystallization indexes, we are not sure that we can use it in our everyday practice. Of course, in every patient, you have to think about the risk of metabolic bone disease and chronic kidney disease. And the last advice that I can give is follow the EAU therapeutic algorithms, even if you are not an expert in metabolic evaluation. As I said, you operate, you analyze the stone, you do the basic evaluation, you evaluate if the patient is at high risk for stone recurrence, you do the 24-hour urine collection, you get the results, and then you advise the therapeutic algorithms for your patients. As simple as that. So when you are in doubt, I think just follow and get the advice of the EAU guidelines. So I have really to thank you for your patience on a difficult topic, I think, and I will be able to take questions and reply to your questions if I can. Okay, one question is how often we follow the patient so thoroughly as I presented. I think it's very important to get familiar with the metabolic evaluation. It's very important because if you do it, you will realize that it's not that difficult in your everyday practice. So really depends on the patient, of course, and how compliant he will be. But it really depends also on us, on the urologist, and more specifically on a dedicated stone clinic. This is very, very important, I think. If you have a dedicated stone clinic, as I showed in one of my slides, you can have a 50% reduction of the stone recurrence. I think this is very important. One difficulty that we are having as a urologist is that we are not familiar with the medication that we have to give, and how often we have to follow, how often we have to repeat. I think it's very important also to do it and to explain to the patient why. Another difficulty that we may have is how we should do the 24-hour urine collection. We are not experts, but be in close collaboration with your laboratory. Another question that is coming is, what about if we can do a 12-hour urine collection? I think this could be an alternative, but there are studies showing that they are not as good, the results, as we can have with a 24-hour urine collection. So I think 2 consecutive 24-hour urine collections are very, very important. Another question that is coming is, what about the percutaneous chemolysis? I think the percutaneous chemolysis is most of the time out of the way because of the side effects. Having said that, if Dr. Tiselius was here, he would say, no, 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 it's very important that you can use it. I think that I cannot recall when was the last time that we did it. I think it's very important to try to clear through the percutaneous tract the whole stone if possible, even if you have to repeat the percutaneous surgery. Another question is, what is the experience with the patient compliance? Unfortunately, the patient compliance is not that high. It's approximate on the long term is approximately 25 to 30%. I think this is mainly because not due to the side effects, but it's very difficult for the patients to maintain the patients on the long run. But as I said, this is a reaction between the doctor, the urologist, or the team, the dedicated stone clinic, to the patient. So a lot of stone clinics, they just give a call to remind the patient for their appointments, and they are not wait for the patient to just come back. And by this, you can really reduce the stone recurrence. So to summarize, if there is no other question, the way we do it, I think we created within the guidelines very nice therapeutic algorithms. This was because we wanted to make it easy for the everyday urologist to deal with the stone patients and the metabolic evaluation. So the idea is to operate, take a stone sample, analyze the stone, do the basic evaluation. As I said once again, it's very important after the basic evaluation to identify whether the patient has risk factors for stone recurrence. If the answer is yes, then you have to do the specific metabolic evaluation. Specific metabolic evaluation, especially for calcium oxalate stones, means 2 24-hour urine collections. Whether you have the results, when you have the results, and the patient is sitting in front of you, and you may not remember what is the treatment of calcium phosphate stones, then what you can do is get the advice of the therapeutic algorithm. You have it in front of you, that was the idea. And based on the results of the 24-hour urine collection, give the appropriate treatment. You have to do it when the patient is stone-free after 20 days. You have to repeat it at 3 months, 6 months, we don't know, but you have to repeat it, that's for sure. And you have to do it annually thereafter. And unfortunately for us, and fortunately for the patient, you have to do it lifelong, which is very important. I have to thank all the presenters for all the participants, and it was a great pleasure for me also.